Hello, and welcome to this AC Forum webinar titled Thrombosis and Antithrombotic Care in the Hispanic Community. This webinar will be highlighting how Hispanics exhibit diverse and heightened rates of cardiovascular risk factors and the importance to understand and address these unique healthcare needs within the Hispanic community. Next slide. As this webinar is accredited, we wanted to make sure and share the disclosures and notification of support for our presenters. And you can see those listed here on this slide. Next slide. This webinar is an accredited 1 hour of Ethics CE. The link will be available in the chat both at the beginning and the end of the webinar, and will also be posted along with the recording of this presentation on our website in just a few days. Next slide. I would like to introduce our moderators for today. Julia Bayadinova is a nurse practitioner at St. Joseph's Healthcare in Hamilton, and myself, Julia Mulheman, a pharmacy manager at the Cleveland Clinic Health System. Julia and I are members of the AC Forum subcommittee called the IDEA Initiative, standing for Inclusion, Diversity, Equity, and Allyship. And one of our goals is to provide webinars directed at such things as health disparities and social determinants of health and topics surrounding those. It is my great pleasure to introduce our presenter today, Dr. Alfonso Tafur. Dr. Tafur is originally from Guayaquil, Ecuador, and earned his medical doctor degree from the University of Guayaquil. He continued his studies at the Mayo Clinic in Minnesota, where he specialized in internal medicine and completed a vascular medicine fellowship. He later earned his master's in clinical and translational sciences from the University of Oklahoma Health Sciences Center, and an MBA from the University of Loyola Quinlan School of Business. Dr. Tafur is currently the Director of Cardiovascular Research and the Director of Vascular Medicine at the North Shore University Health System in Illinois. He also serves as Program Director for the University of Chicago NSUHS Vascular Medicine Fellowship Program. Dr. Tafur's clinical interests include value-based healthcare and implementation, and his portfolio features over 150 publications focusing on thrombosis risk prediction and perioperative anticoagulation. He co-authored the current perioperative guidelines by the American College of Chest Physicians and has been an active member of PAUSE, the Perioperative Anticoagulation Use for Surgery Evaluation Group. Additionally, he serves as co-chair for the SSC Subcommittee on Perioperative and Critical Care Thrombosis and Hemostasis for the International Society of Thrombosis and Hemostasis. Please join me in welcoming Dr. Alfonso Tafur and the wonderful presentation he has put together for us today. And before he presents, I just wanted to let everybody know if you do have questions during his presentation, to please put those in the Q&A box. Thank you.
Julie, thank you very much. I really appreciate this invitation, honestly. This is an important topic for me. I'll throw that picture out there to tell you a story. So let me bring you back Chicago weather of December 17th, a little bit more than a year ago. And I was home alone because my family was already in Mexico. I'm from Ecuador, but my wife is Mexican. So they were waiting for me to spend Christmas holidays over there. Nobody else at home likes liver, but I do. You know, that's what my grandma used to make way back when. So I will not invite you to to sort of sense the smell of those sizzling onions and the aromatics and etc. Because I very well know it's a bit of a acquired taste. But I was cooking that right after I had gone for a run. And I overdid the run. I remember that much. While doing that dish, I ended up having this kind of a lower belly discomfort that I couldn't explain. And I assumed, you know, you overdid it. Have not eaten all day. And so this is your body asking for sugar. So I sugar out myself, and then I lay flat on the floor, turn the stove off just a bit. It actually went away for a little bit. So go back to it. And now the thing starts changing now. So now I'm having these sense of palpitations, nausea, discomfort. So something's off. I still want to make myself believe this is indigestion of some sort or sugar, overdid my exercise, and I lay down on the floor. But now my hypoxic brain is acting up. So middle of winter Chicago, I go ahead and open the front door, just in case actually have to call 911, and then I don't want you know, the fire department breaking my door. So long story short, it doesn't go away. Then I go down my differential and I figure out this is something else. So in my hypoxic brain, and I do not recommend you to try this at home, I get into my car. I know that I live very close to the hospital, so I'm going to drive there because I sort of calculated the time it would take me, and I thought it was the safest route. And I make 2 phone calls. Phone call number 1, I call my wife and I tell her, hey, I love you, love your kids, and just FYI, keeping my cool down, right? FYI, I'm driving to the hospital. If I don't call you in about 2 hours, call Glenbrook Hospital directly, ask for me. I think I'm having an MI. I think I'm having a heart attack. Then I call my friend, who is an interventional cardiologist, and I tell him, hey, are you on call? No, I'm not. Well, anyway, so 2 messages for you. Number 1, call whoever is on call. Go ahead and have a tentative activation of the cath lab. I will be needing a procedure in the next few minutes. I think I'm having an MI. And please call the ER physician, have him ready for me. I'll be walking in the door in the next 5 minutes. I want an EKG right away. And I don't joke. So he knows this is not a prank call. Everything was ready. So I'm walking through the ER, and the ER physician is ready for me. I kind of do a registration just on the way, EKG, and I know that she has seen this thing for 1,010 times, and this is nothing new for her. But she looks at the EKG thing, and then she flips it, shows it to me, and she's kind of pale, surprised, unwishful. And yeah, there it was. So paddles on, walking through the hallways. First time I ever see the ceiling of the hospital, because that's not the thing that you look at, as I was getting rolled to get my LAD opened. So all of a sudden, I changed from being the physician in that hospital to 44-year-old Hispanic male STEMI. And as I'm remembering that story, I remember being rolled through the hallways, and 2 things I'm thinking. One, I'm thinking, you know, I did okay for my family. So whatever happens, I know they're taken care of and they have a wonderful mother. So be it as it may. And number 2 thing I'm thinking is, what the hell happened? So what the hell happened is that I'm here for this lecture. And I'm going to decompose that storytelling on a cardiovascular thrombotic care in Hispanics in 3 segments. So first, let me analyze what are those things that makes us more or less prone to it. Review what's the reality of the current numbers US-wide. This will make more sense later, but I'm going to deconstruct this paradox concept. And then finally, I'm going to share with you what I've learned through reading and through personal experience on which things to maybe consider when we are caring for a Hispanic background patient who is encountering themselves in the need of cardiovascular and thrombotic care. Now, regretfully, let me start with this premise. We do not have the greatest data sources for this. There's this concept, I want to name it, of nurture and nature. So you may see here, I mean, the global rates of thrombosis, venous thromboembolism specifically now, among the Hispanics, not the highest, reportedly. Maybe because of surveillance, maybe because of different genetic predisposition, but let's decompose that. And I realize this is a bit of a made-up dichotomy. So we all have our genes and we all have the things that we do for or to ourselves. But at least for organizational issues, let's try to divide this story on there's some genetic components that may be less frequent actually in Hispanics, maybe some acquired components like antiphospholipid syndrome. I'll touch base on that. And then the others that there's a flip of how much nurture and nature actually play a role onto them. So I told you that we don't have a whole lot of information in some things, and this is a good example of it. So these are the rates of genetic predisposition among Hispanics in a relatively small study. So less than 100 people, actually, very small study. Predominantly Mexican Americans, right? So not representative of all ancestries. And really, the rates of genetic thrombophilia markers, not very high. Much higher for MTHFR than expected for other cohorts. But that being said, MTHFR is not really the most important predictor that we could be thinking, and the value of it is, as a whole is limited. I do find it interesting, this report of activated protein C different to 5-lighting itself. So perhaps a gap on other less evaluated mutations on the factor 5. But this remains speculative, and quite honestly, these are relatively low rates of genetic predisposition on the genes that have been well evaluated in Northern European or white societies, right? Because the generative information, the actual discovery of data of genetic thrombophilias specific to Hispanics, we do not really have a lot of data on that. So this is what we know. There will be more that is just unknown. Now, I remember a different concept as far as genetic predispositions, and I want to put attention to this one. So if you define thrombophilia in a broad sense, you will find the definition of a blood disease that is associated with thrombosis. So let's bring sickle to the perspective here. So sickle, it is a blood disease. I mean, there's a diverse population in the chat here. So to take no assumptions, I mean, you have the red blood cell that has a genetic mutation, so it deforms depending on oxygen consumption, and then it can clot the vessel. It can explode, and then it expels hemoglobin and changes the phosphatidylserine exposure, and that generates blood clotting. So if that hypothesis is true, it will associate with clotting, and the answer is that yes, it is. Sickle will be associated by about almost 15 per 10,000 people likelihood of clotting in carriers, not necessarily sickle disease, but any carrier, relative to, let's say, measure a rate of expected 8.8 or so per 10,000 population in the rest of us. So yes, it is associated more than 2 times more likely to have pulmonary embolisms, even after adjusting for other covariates. So in a sense, I will like to name this as a thrombophilia as well. And granted, it is going to be most common in Black Americans. In the California database of almost 7,000 patients with a sickle, 7% of them are Latinx. So bear in mind, this is a genetic thrombophilia that should be considered prevalent in Hispanics. Now, let me move to an acquired risk factor. So antiphospholipid. So I explain it to my patients as, you know, you have this antiphospholipid thing, and then imagine you have your soldiers. So your soldiers go fist to fist with the fighting of bacteria, let's say. So that's the neutrophils. And then you have other smarter ones that actually from far away, they send arrows. So these are the arrows that sometimes they kill the innocents, right? So I remember reading back when I was in med school, these obscure papers saying that the rates of antiphospholipid antibodies were very high in Hispanics. That wasn't the best data out there, quite honestly. This one is. I mean, this one is a prospective Dallas Heart study, almost 2,500 individuals, multiple diversities. A percentage of them are Hispanics, about 14% with these 300 individuals. All of them tested for multiple antibodies, as you see on charts. And I was sort of right. Yes, the rate of beta-2 glycoprotein was higher in Hispanics relative to other populations. But no, I was not right. I was wrong. It's actually not any more common when you see the cumulative risk, meaning the global perspective of any antibody positive, not really much more common to have antiphospholipid in Hispanics relative to other groups. So a bit of a fake memory that I have in there. That being said, it does matter. So it did associate, and we know it associates with future outcomes and cardiovascular outcomes and thrombosis, of course. So let's change from one risk factor that these maybe are not as common in Hispanics to something that is categorically common in Hispanics, and that's rates of obesity. Not only because of nurture, also because of nature. What I mean with that is that Hispanics we do have a especially high rate of some SNPs, some genetic modifications that will be associated with triglyceride metabolism, with a higher accumulation of fat, with higher waist circumference. And when turned on, so to speak, and we start living in the United States exposed to a different type of acculturation, we are actually going to have high rates of obesity. So 45.6%. So give or take, half of us will have obesity. Other factors that maybe add to these, well, in Ecuador, you always have some rice and plantains next to your food. Very high caloric intake right over there. As I mentioned, my wife is Mexican, so I'm always having some tortillas next to my dinner. So there is this dietary aspect to it. Some other things that are not purely cultural. I mean, because we do have less insured population, we do have less access, and you would ask, well, what does that have to do with obesity per se? Well, it's access to options, access to care. Not only access to that, but there's an association of obesity with rates of activity. So think about it in a broader sense: access to parks, access to exercise equipment, access to locations where you exercise. And then that also has been proven in other publications to be a factor implying this rate of lesser activity among Hispanics in some scenarios. So there goes obesity. Now let's talk about a little bit of all of those cardiovascular risk factors, and this goes into metabolic syndrome. So as a reminder, metabolic syndrome will be associated with coronary artery disease ×2, for example. Coronary metabolic syndrome factors, which some of them are here, will also be associated with thrombosis, VTE, venous thromboembolism recurrence, almost by a factor of 1.4 to 1.8, depending on the factor we're looking at it. So let's talk about hypertension in Hispanics. And you'll see these rates of 1 in 4 Hispanics expected to have hypertension, 1 in 2 hyperlipidemia, 1 in 5 diabetes, 1 in 4 smoking. So these are very low denominators. I mean, the chances are you will find some of those factors. And then the common offenders, right? So lesser education or less household income will be associated with worse prevalence of the disease. I'll take a minute to some story that is interesting, at least in the hypertension aspect. Stress will be associated with hypertension. Well, that makes sense. What is a little bit more interesting, I would say, is that the number of traumatic events measuring the lifetime of this Hispanic person is inversely related to hypertension. Just as if the longer we're exposed to trauma, we do learn to be resilient. And I really loved on this study the value of simpatia, they call it. So basically, how good and how strong is your social support? The higher it is, the lower rate of hypertension, which kind of starts throwing an open door out there to which may be the things important to consider when you look into ways to modify care. This slide looks a bit funny on my presentation here. I don't know if it is actually for all of you, but let me actually talk about what should be seen. The rate of metabolic syndrome varies a lot depending on subpopulations. And then the subpopulations that I mean is when you do a study in which they were subsets of individuals from multiple backgrounds of Hispanic heritage, there was a huge difference on the amount of metabolic syndrome. Let's say on 60-year-old females, about 60% of them will actually have metabolic syndrome. Compare that to 27% of South Americans, compare that to 41% of Puerto Ricans. So a huge variation depending on which specific Latinx or Hispanic group you're considering. So if we have these many risk factors in our background, is there a sense of which of these is worse for my people or for us? Well, the common offenders are here. This is an actual study on about 1,500 individuals of multiple backgrounds. It was a case control, so 1,400 that had sudden death. And then compared to 1 to 2, compared to basically 3,000 Hispanics from a different denominator. And then you see that the risk factors for sudden death among Hispanics, the common offenders of cardiovascular disease, but by a multiple fold, 7 times higher was the rate of CKD. So chronic kidney disease, probably the one thing that we ought to be looking higher into. So from that aspect, I go to the next one, which is if it's true that there is a high rate of risk factors among Hispanics, let me try to understand what is the impact of those risk factors into actual outcomes. So how many of us are actually having cardiovascular events? So let's start with this picture to try to bring some pathobiology into it. So this is called FMD, so flow-mediated dilation. So relatively simple study. I'll go into my artery and then I put a blood pressure cuff. As I put a blood pressure cuff very tight, I create distal ischemia. So the normal looking vessel, the reactive vessel, will open up and dilate. And that measure of dilation actually relates to a healthy vessel, right? So if I look into individuals, Hispanic individuals with some degree of metabolic syndrome, there is an actual correlation with diabetes, with hypertension, with visceral fat, and worse vasodilation than expected. But interestingly, in this study, which was reasonably sizable, I mean, almost 1,000 patients, 160, the actual rate of vasodilation anomaly was not as related with Hispanic lifestyle and Hispanic BMI per se. So I think that was a bit of an interesting dichotomy over there, which starts lending the idea that maybe the risk factors are not measured equal, and that might be what trends to happen on something else. So again, I don't know whether this slide is actually projecting well or not because it looks funny in my computer, but nonetheless, what I'm trying to show right now, or what I will tell you about a story on, is that in about 1 million hospitalizations, measuring the rate of hospital-associated thrombosis, the rates among the 15% group Hispanics that was represented in that group was actually lower. So again, high rate of risk factors, but representation of Hispanics, when you take a look at Hispanic-specific thromboembolism in hospital associated, lower, even though the global trend in those million people had actually been trending upwards. Well, that's funny. Well, this is actually the slide I was trying to show you. Kind of flips here, sorry. So you see those rates kind of trending upwards. You will see the COVID spike over here, but nonetheless, as I was mentioning, the Hispanic group, if anything, 0.83, which is basically, give or take, 20% lesser. From that aspect, I can argue in that prior publication, well, that's database, right? So it may well be that some of the Hispanics are underrepresented, or some of the outcomes were not really reported. I can speculate a lot of things. So let me look at it from a different perspective. So this is Professor Wendelbo. He was actually one of my epidemiology professors up in Oklahoma. So he did this study with active and passive surveillance of outcomes. So let me expand on that. So one of my arguments could be maybe Hispanics are not having the expected rate of outcomes in thrombosis because we're missing them. So, but Wendelbo actually did active surveillance. So he literally went after acquiring more data of actual thrombotic outcomes and passive combined, meaning just absorbing information from databases. And still the outcome was that the expected rate of thrombosis was lower. So globally, it was about 2.47 per 1,000 individuals in this Oklahoma registry, whereas it was highest in African Americans, 3.25, then in Native Americans, 2.7, and then Hispanics, 1.25. So categorically, I'm seeing this thing again in which the actual rates of thrombosis, now measured in a different way, were lower. So how do I keep on trying to challenge this idea? Is it really then that we have lower rates of thrombosis? So again, let's look at it from a different perspective. Because if it's really true that we're having less outcomes, I should be a parallel mortality change. And indeed, that's what we see here. Comparing with multiple ethnicities, races, you will see that in time, so this is a cohort of multiple years of information looking into the average annual percentage rate change. So how much are the rates of thrombosis changing? Well, number one, we see that everybody's getting worse. Well, that's already important, of course. But we see that Latinx are not getting worse at the same rate, at least in this aspect. So 2% percentage annual percentage range for Latinx, where we was higher for white, 2.7, for example. So indeed, there is a progression. Hispanics are not faring equally bad as far as thrombotic outcome rates. So I think of cancer as a great equalizer in thrombosis. Patients with thrombosis and cancer have a completely different story and trajectory, which may be a different topic in the future. So let's look at that story here. And then you will see on the red bars over here, those are Hispanic individuals, whereas Asians in the green, as you see the pictures here. Every cancer has a higher or different association of thrombosis. So we see the known rates of lowest with prostate and breast, much higher ovarian, brain, pancreas. That is well known. But then Hispanics did not do categorically worse as far as rates of thrombosis. And this is a sizable database of 6 million patients from the Cancer Registry of California. So again, this story that I'm telling you that maybe the rates of thrombosis are not as high seems to be true. Now, if we don't have them, all of them, I mean, are we being treated the same? And then I do see something different that matters here. So among patients with venous thromboembolism who get into the hospital, pulmonary embolism offering for catheter-directed therapy for Hispanics was actually lower. So again, yes, the rates are lower, but then you get to the hospital, and not only the rates are lower, but the actual mortality, Hispanic male mortality on this picture and Hispanic female mortality was actually higher for us. So that should put some time to think. Let's digest a different story. So if I actually have low outcome rates of thrombosis, venous thromboembolism, what about the outcome rates of peripheral artery disease? Now, granted, this is a bit of a projection information on this study, There were 6 different community-based cohorts grouped all together to create these projections of the impact of peripheral artery disease in Hispanics. And yes, it increases with age as we would expect, but it actually falls short of having the highest dominance in Hispanics relative to other races. I mean, much more in parallel with Hispanic whites, much higher with Black males in these cohort projections. So PAD, not higher outcomes. What about coronary artery disease in general? So when I look into coronary artery disease, despite the fact that I proved to you, we do definitely have very high rates of metabolic syndrome and sedentarism and obesity and risk factors. The fact is that when you looked into coronary artery disease likelihood, the cohorts are not high. So number one, you're seeing something nice here, that everybody's rate is going lower. And specifically among Hispanics, it actually was even lower. So not a very high rates of thrombosis, of cardiovascular outcomes here. The exception on this cohort was actually heart failure. And specifically in heart failure, males under 45 had a higher inflection of mortality increase and a higher inflection of rates relative to other coronary outcomes. So beware of that. I would argue maybe they actually, this is argumentative, not speculative though, maybe they're actually having less rates, but then the aftercare has some room for improvement, which is the heart failure. So am I confused? I think we should be a bit confused. So I've told you that we have high rates of predictors and not high rates of outcomes. So when we have that, we call it a paradox, right? So there's some inconsistency, there's some mystery, dichotomy, you name it. There's something that doesn't click. And some of the arguments that have been presented on this so-called Hispanic paradox, that is the name, is that maybe I'll stress, Hispanics actually have some other type of healthcare advantages, that despite the factors and socioeconomical impact, the rates of outcomes are actually lower. And then one of the arguments was, yes, I mean, the diet is carbohydrate rich, but Hispanic diet would also have high frequency of fresh produce. Sure. Then there's even this idea that there's a selective migration. So in order to cross the border, if you have selective migrant, I mean, you actually have to be fit to even go through that. And then there's this idea that some of the works that Hispanics do actually are more labor intensive, so they're physically more active. So a lot of hypotheses actually trying to suggest this, but let us take another look and try to deconstruct it. Let's destroy this idea that is maybe a bit more of a house of cards rather than full truth. Because when we look at peripheral artery disease, for example, the rates of peripheral artery disease seem to be lower in Hispanics, but if you see specifically at amputation rates, they're actually high. So the blue line horizontal, that's expected for white Americans, whereas the rate of amputations, if you're Hispanic with peripheral artery disease, is going to be higher than the expected average. Same for critical limb ischemia, so higher rates of major adverse limb events in the Hispanic community. So this is a database for over 8,000 individuals, and the rates were in about 13 for white, whereas it was 17.2 in Hispanics. Let's take a look into something different to try to deconstruct this paradox and see whether all of this is true. And there seems to be a correlation between how long have you been in US and therefore the expectation of having different outcomes, which starts making sense. So if you migrate late in life, and this is going to be important for how we care for people, migrating late in life, you're going to have less resilience to adapt to the whole system. If we look at hypertension as is expressed here, the longer you've been in the US relative to foreign born versus Hispanic US born, there is a difference on the rates of outcome for hypertension despite the risk factors. So how long you've been on it, it probably makes a difference. This paradox is really relative to a very simple formula, right? So how many patients I encounter and how many patients I'm actually measuring. So keeping in mind that simple division, let's talk about a few things that maybe are not fair for this paradox concept. For instance, it's true that the undocumented immigrant will have a lower likelihood of reporting health conditions. So self-reported data are going to be lesser, just for the fact that you're not as transparent if you don't have papers. When you analyze data from these major databases, you see this phenomenon of not missing at random. Let me explain to that. So when I have a huge database, there's always going to be something missing. And if it's missing at random, I just go ahead and throw the statistics and then whatever comes out, I believe it. But then the lack of missing at random means that there's some selective missing in which it looks as if there are some aspects that are being underreported specifically in Hispanics, and therefore this calculation numerator denominator no longer works. Supposedly, there's a lower incidence of smoking on Hispanics, but that being said, it varies a lot depending on which Hispanic you're counting. Are you counting Cuban Hispanic or Puerto Rican Hispanic or others? There's a high variety, which really goes to this concept that I think is going to be the most important. It's a diverse community. So the same risk factors that you calculate for Hispanics in general and Latinx in general are going to be very different depending on which subgroup you actually look into. And ultimately, this slide actually, I think, explains that very nicely, comparing the diversity of the foreign-born Hispanic. And you will see this line is actually for males and then for females, looking into the outcomes of and the acculturation and the outcomes on cardiovascular health. And you will see that there's a big variation here in different Hispanic groups versus the probability of outcomes. So you will see that those little stars that are plotted out there are statistical significance. Now, compare and contrast that versus the rates that you will expect and see on US-born Hispanics. And then all of those discrepancies between subgroups start disappearing. So it goes to the idea that Hispanics are not only different depending on where they're coming from, there's a huge variation on expected outcomes depending on how long we've been in the US and whether you're Hispanic-born or not. So maybe I can look at this in a yet one different way. I think it's skipping one slide again, sorry. So if you look at a group of Hispanics and then you go into this study, this is not a reference slide, but there's a study called the All of Us study. And in the All of Us study, there were 202,000 individuals collected. It was a good study with excellent capture. And then there were 40,000 Hispanics actually represented there, making it by far the largest Hispanic population representation research trial. And in that subset of population, when you measure it with modern information, the rates of cardiovascular outcomes, coronary artery disease, was highest in Hispanics relative to the other races. So let me repeat that. So in a large, well-performed study, modern study, 202,000 people, 40% Hispanics, the actual rates were higher. So maybe this paradox concept is because we've been trusting all their information to make future predictions, but we're not even near measuring the actual current real rates. There are differences in other aspects. You will see on this graph, actually, that the rates of cerebrovascular disease, for example, is going to be much higher in Mexicans than in other Hispanic populations, whereas that is not the same case for other ischemic heart disease, for example, way higher in the Cuban American rather than other Hispanics groups. So this goes again to tell you that rates are expected different. So let me paraphrase here as I go to the very last segment. So number one, we do have high rate of risk factors. The outcomes do not reflect that. It may well be the outcomes are not reflecting that because they're really low. Plus, there is a lot of differences that we have to be more specific about to understand what really is happening among our communities. But ultimately, let me share with you some facts about how we care for people with cardiovascular and antithrombotic disease. It's true that after you arrive to the hospital, Hispanics and Blacks will have a higher rate of leaving against medical advice. When you control for the location of the hospital, that effect disappears a bit, which goes to show you that it's about access to care. The same visual for socioeconomic outcomes, for socioeconomical aspects will impact healthcare in Hispanic. That is very well known. So one of the things that we ought to look into for reevaluating policies of care is precisely looking at those healthcare disparities. One of the most important things I learned throughout this lecture and discovery, we're all different. And then these pan-Hispanic and Latino terms leaves a lot on the table as far as our true heritage and actual impact and prevalence of the many risk factors that we have. I made this slide, and I think it actually accumulates in a single picture the things that are important for me as when I see the Hispanic care. One, of course, I have to be cognizant and disappear as much as I can this disparity, at least if nothing else, with high awareness. Other factors, so socioeconomical, rethink the race as far as which is the real ancestry that we have. Be cognizant that the needs may be different depending on how long you've been on US, both because of impact of health factors and also because of impact of access. And ultimately, my biggest ally, I mean, I share with you that the first thing I was thinking when I was having my own event was family. Whenever I treat Hispanics, I try to engage with the family, not with the patient alone, because I know that the nucleus of that family is what's going to bring us to fruition. And then I get that daughter, I get that uncle or that relative that is actually sometimes in the same household, as to make them participant for and a partner in developing healthcare for any Hispanic outcomes. So on that, I'll be closing with these four aspects that we've gone this trajectory through, dissecting the risk factors, contrasting what we actually see, what we actually believe that the outcomes may be, and then stressing that that dichotomy between risk factors and real outcomes may be because the data continues to evolve, but now we know which are the factors we ought to look at. So I'll open to questions there.
What a great talk, Dr. Tafur. Thank you so much for taking the time to be here with us today. It really highlighted the challenges that the Hispanic population faces when it comes to cardiovascular disease and thrombosis. We have quite a few questions from the participants here. So I will start. Do you have any resources that you can share for either the Hispanic population, the patients, or providers that are providing care to these patients that can maybe be, you know, a part of a public health advice, some of the recommendations that you presented?
Well, I mean, this whole slide set is going to be, of course, available. I think the Anticoagulation Forum will have these segments of additional type of help. I'm sorry to say that there's a lot that is still evolving, I would say. And then the additional specific resources, I'll put myself available, but the additional resources specific or translated, inculturated to the community are still being built. I am actually working in a committee to try to give that information for both peripheral artery disease and for venous thromboembolism. The final product is not ready. We do expect it this year. So I'll be sure to share with Anticoagulation Forum when that becomes available.
Thank you. Another question. I know a lot of us here on the AC Forum, pharmacists, nurses, providers are, you know, really taking care of our patients' anticoagulation needs. And so with that, a lot of us have patients that are still on warfarin. And one of the things that there are a couple of questions in the chat regarding is the cultural differences, or those traditional foods. I know you mentioned some of them at the beginning with the rice and plantains, tortillas, and fresh produce. Specifically some of that fresh produce. Are there traditional foods or even activities within the Hispanic community that would potentially be contraindicated with the anticoagulant therapy, whether it be warfarin or DOACs?
Thank you for the question. So I see it a twofold question there. So foods that may impact the warfarin specifically. So in general, for example, precisely liver or avocado will have a reasonable amount of vitamin K. So that you may make people cognizant about that. At least personally, in general, I stress them to make sure that there's more of a constant diet rather than making people avoid any particular certain foods. As far as activities, though, I don't see it as far as something like that impacting healthcare outcomes or specifically dangerous behaviors that could actually impact higher bleeding rates. In general, I grew up with a community, or I see Hispanics as liking exercising within community sports and potentially contact there, of course, but not to the level as to make it threatening, dangerous to get high impact bleeding rates on that.
Great, thank you. Another question that came in that I thought was really interesting, since I'm very interested in patient education myself. Can you maybe share some patient education strategies that we as healthcare providers can use when treating the members of the Hispanic community?
Thank you for that one. So patient education. I enjoy patient education even more so than I do physician education. And let me explain that a little bit to unpack it better. Whenever you talk to an adult and try to educate them, the hardest thing is to spark interest. And the patient already comes with an embedded interest. So that's the nice part. Being non-assuming. I mean, often we have some lexicon changes that I've been surprised of how different they are. For instance, in Puerto Rico, they will tell me about the vein. And the vein may actually be talking about an artery. So we confuse terms as far as circulation and the vein, very often not referring specifically to a thrombosis in the artery or the vein. And then I have to kind of trigger more questions to understand what we're talking about to meet them where they are. As I mentioned during the lecture, my best ally when I'm treating my Hispanic patients is to make sure that I engage their surrounding community and I understand which are their surrounding community. I have patients who very often will come with almost always, they will come with somebody else to the office. And then I need to understand which is the level of community living that they have that impacts their own engagement with healthcare. So I think that's probably my main source of communication, understanding where they are, asking multiple questions about it, and then engaging their own community.
Thank you. I have another question that really does relate to patient care, and it kind of circles back to the one slide you had in regards to antithrombotic care delivery for Hispanics, and kind of going down through those points of potentially some barriers, and really, what are the barriers to care that you see for the Hispanic population, and how can we help overcome these barriers? I know with our group, the IDEA Initiative, we probably a few years back now put together a rapid resource for the social determinants of health. And it's just a quick, one pager back and front. And on the back, it gives some discussion in regards to considerations that providers could potentially use when they're sitting with a patient and going through what some of these barriers may be. But I know a lot of times we have 15-minute appointments, so we have a short time with these patients. So I don't know if maybe you have some ideas or some recommendations for how to tackle those barriers in a short amount of time.
Well, first of all, probably I don't have any trick to actually make a 15-minute appointment equivalent to an hour. I mean, that's just nature of where we are right now. But being highly aware and alert of some of those potential barriers might help us put more time into different things. One aspect that I didn't mention, but I found both my perception and I found it now in literature as well. Uh, who do we trust? We often have these stories of mother and grandma, which were the main Dr. Mom growing up, and then these beliefs of what they said are the real first things to approach in healthcare are still ingrained. And then we can battle them, which would not be smart, or we can integrate them into the healthcare idea. So what do they tell you that you can do? You know, this one is a good idea. This one actually you can probably alter a little bit. As long as it's not dangerous, we can actually integrate those historicals and cultural perceptions into the actual healthcare. So that I would approach that. The second one that is regretfully prevalent is really access. I mean, the rate of uninsured Hispanics is high, and then we'll have to partner with looking into additional resources.
Great, thank you, Dr. Tafur. Just going back to patient education and provider education, do you have any suggestions as to how we can increase the knowledge about the risk factors, specifically about Hispanic patients among other disciplines or other healthcare providers?
So one of the best perhaps approaches that I like for education in general is just-in-time education. As I mentioned, the first barrier is to even get the interest. Now, there's this moment in time in the adult life cycle in which we do have an interest, and having early access to that is actually optimal. For instance, if you have this is probably harder than we have right now, but it probably should be the future. If I get not just of education or not just of information specific to my patient when I open my EMR, which we have implemented in my system for some aspects of venous thrombosis care, that moment I'm paying attention because I'm heavily invested. So if I have one patient with a specific risk factor that the EMR knows, and I be sent a little flag of reminder, then that's a moment in which I pay attention. I have openness to education. The other aspect of education continuum of making a difference is, I believe, the ADCAR model, which basically starts with creating as an acronym. So high awareness, then high desire. So finally making a knowledge acquiring, and finally restructuring of change. So creating awareness would be about repetition, and then having early and frequent access to that idea that sparks there's a difference here, so that eventually we create the desire of learning something different.
Thank you, Dr. Tafur. And just to conclude today's presentation, first of all, again, I just wanted to thank you very much for your insightful presentation, and a reminder to the audience that this webinar was recorded and will be available on the AC Forum website shortly. Don't forget to claim your Ethics CE for your participation in today's webinar. The link is available in the chat and will also be posted on the website. This website was coordinated by the Anticoagulation Forum's Inclusion, Diversity, Equity, and Allyship initiative, which strives to promote opportunities for clinicians of color in the AC Forum leadership and programming, as well as supports the development of a variety of educational content on health disparities. And before we go, I would just like to share a few quick announcements. First of all, we're really excited to host 2 webinars this month. Be sure to join us next week for a discussion on anticoagulants in older adults. A link to register will be posted in the chat, and you can also find more detailed information on the webinar page of the AC Forum website. After a 6-year hiatus, bootcamp is finally back in person. Join us in Music City, Nashville, Tennessee on May 17th and 18th. This intimate meeting is a great way to learn the essential aspects of anticoagulation, disease state, and drug management. Register today. And if you're interested in attending THSNA, be sure to check that you're affiliated with the AC Forum when you register. And again, thank you for joining us, and thank you to our guest speaker, Dr. Tafur.
Thank you much.